Welcome. Today we will be talking about the fluid requirements in pediatric practice. Now we will try to make it as simple as possible. Remember, when you are giving fluids to any pediatric patient, there are two conditions in which we give them fluids. Number one is we are trying to resuscitate them, so they are in some volume depleted state, and that simply means that the fluids inside their body is less in quantity. So we need to immediately resuscitate them. We need to immediately infuse fluids into them so that they become normovolumic. So from a hypovolumic state or from a low volume state, they go into a euvolumic state. So we call it the resuscitation conditions in which we would give them fluid. And the other condition in which we have to give them fluids is what we call the maintenance condition, in which we have to maintain their normal intake of fluids because for some reason, like because of an illness, because of some GI condition, they are not able to hold up their maintenance fluids, or in other words, they cannot take oral fluids. So we have to give them maintenance fluids. So at least their requirements for the 24 hours is fulfilled by infusing them with maintenance fluids. So, without further ado, let's start about these two conditions. Resuscitation conditions, usually, if a child is in shock because his blood pressure is down, his heart rate is up, he has lost his volume. It could be because of many conditions. It could be because of septic shock. It could be because of dehydration, because of vomiting and diarrhea. It could be because of some other like prolonged conditions in which the child has not been taking enough fluids and eventually he ends up in a shock like conditions. So, in all those conditions in which there is shock, we need to give them resuscitation fluids. So, in other words, these are all volume depleted states in which the body fluid volume is reduced. Normally, we have got two choices of fluids in this particular condition. One is 0.9% sodium chloride, and the other is Ringer lactate. Now, remember, as far as these two fluids are concerned, they are the same. The only thing, Ringer's lactate contains a few more things like potassium, so it contains like 4 millimoles of potassium per liter, and sodium chloride is just like isotonic sodium chloride. Usually, Ringer's lactate is the fluid of choice of the surgeons because they usually give these fluids perioperatively or post-operatively to the patients because obviously they have lost volume during surgery. While 0.9% sodium chloride is the fluid of choice for the physicians, like especially in all those medical patients who are in a shock-like condition or who are in a volume-depleted state, they are given 0.9% sodium chloride. So usually we give them the bolus amounts. In other words, we give them like 10 to 20 mils per kg body weight, and it's given as a bolus, like you give it a push and you try to bring them to a euvolumic state. So remember, for resuscitation conditions, there are two fluids: 0.9% sodium chloride and Slinger's lactate. And for most of the physicians, like especially in pediatric practice, we use 0.9% sodium chloride. Now, maintenance fluids are required for those patients who cannot tolerate oral fluids and they need IV fluids to maintain homeostasis. In other words, they need IV fluids over a period of time to maintain their euvolumic state, but they are not dehydrated, but they just want, otherwise they will go into a dehydrated state. So for that, the choice of fluids is either a 5% dextrose with normal saline or a 5% dextrose with half saline in pediatric practice. But again, depending on the availability, usually we go with 5% dextrose plus normal saline because that's the most readily available maintenance fluids in most of the emergency departments as well as pediatric departments. Okay, moving on to talking about calculating fluid requirements. Now, fluid requirements are calculated on different what you call needs, whether the child is in resuscitation condition or whether the child needs maintenance fluids. Now, as far as the resuscitation scenarios are concerned, remember, if a child is in shock because it's a septic shock or it's because the child is simply what you call in a hypovolemic state, we give them bolus fluids. Bolus means we give them a straight push. We do not give it over, let's say, half an hour or 20 minutes. We just give them as quickly as possible. And the starting usually dose is 20 mils per kg. So 20 mils per kg is what we use, and we can repeat it at least 3 times. So a total dose of 60 mils per kg can be given. In trauma, we have to be a bit careful. Remember, the trauma guideline says that you have to be a bit careful. So you have to give 10 mils per kg. We do not give 20 mils per kg. So in all pediatric traumas, we give 10 mils per kg. If it is a condition of dehydration, so if a child is dehydrated because of prolonged vomiting, again we have to calculate the deficit, because obviously ongoing we need to know an accurate estimate of how much deficit that child is in terms of his volume. So the formula for that is we take the body weight, we multiply it by dehydration, multiply it by 10. Now, basically, this ideally it should have been the difference in body weight that tells us like how much of that child, the child, how much dehydrated he is. But this simple formula, if you take the body weight at that point in time and you multiply it by percentage dehydration, now percentage dehydration is like it's a clinical assessment. So again, depending on the how you classify dehydration, usually WHO criteria is a very good one in which you will see whether the skin turgor goes back immediately, whether it goes back within 2 seconds or more than 2 seconds, whether the eyes are sunken or not, whether the mucous membranes are moist or not in small babies, whether anterior fentanyl is depressed or is normal. Again, you would classify them into mild to moderate and severe dehydration. So mild to moderate dehydration is around 5%, while severe dehydration is around 10% or more. So remember, the body weight multiplied by percent dehydration multiplied by 10 gives you the amount of fluid that has to be given. But remember, this has to be given over 24 hours. You do not give it as a bolus. Bolus fluids are only given in conditions of shock. Apart from that, if the child has got deficits, you will cover up these deficits over 24 hours along with their maintenance fluids. Now, maintenance fluids, as far as they are concerned, we use the Horley-Seger formula, which is like it is 100 mils per kg for the first 10 kilograms. After that, it's 50 mils for the next kg, 10 kg. That means between 11 and 20. And for every kg above 20 kilograms, we use 20 mils per kg to a maximum of 60 kilograms. So remember, if a dude is more than 60 kilogram, again, you would not go more than that. And again, the maintenance fluids are given over 24 hours. So whatever fluids requirement you, for example, if a child is 10 kg, so 100 mils for the first 10 kg would be 1000 mils. So when this 1000 mils have to be given over 24 hours, so you will divide it by 24, and that would give you the hourly rate of the maintenance fluids that you have to give. And I told you that the choice of maintenance fluids usually that we use, there are different fluids, but we use 5% dextrose along with 0.9% sodium chloride. There are certain conditions in which there might be some degree of fluid retention. We call it syndrome of inappropriate antidiuretic hormone. And in that case, we have to go slow. So instead of giving them the full maintenance over 24 hours, we give them two-thirds of the maintenance because they are already retaining fluid because of this inappropriate antidiuretic hormone secretions. And that's usually occurs in conditions like CNS conditions. If somebody has got meningitis, encephalitis, or head injury, or has got a low GCS because of anything, or the child has been suffering from seizures, or he has got chest conditions like asthma, bronchiolitis, pneumonia. These are the conditions in which there can be an inappropriate secretion of antidiuretic hormone. So we give two-thirds of the maintenance over 24 hours. So like for example, if a child requirement is 1000 mils as a normal maintenance, two-thirds of that would be 670 mils, which you have to divide by 24 to get an hourly rate, which you give over the next 24 hours. Okay, then moving on, let's talk about some examples and that will clarify these things. So let's say a 12-kilogram child who has had fever for the last 5 days and he has been vomiting as well. So now he presents with a temperature of 39.6 degrees Celsius. He's got heart rate of 205 beats per minute. His blood pressure is 50 by 30 and he's got a central gap refill time around 4 seconds. So this criteria tells you that this child is in shock. He is in a hypovolemic state. So how much fluids you are going to give him? Now obviously at this point in time, because this is an emergency, he's in shock, he needs resuscitation fluids. So resuscitation fluids, the choice would be 0.9% sodium chloride. So in this case you would give him 0.9% sodium chloride. Now how it has to be given? It has to be given in a dose of 20 mils per kg body weight. So 20 times 12 would be how much? This would be 100 and sorry, that would be 240. So he needs 240 mils of 0.9% IV as a fluid bolus. So he needs a fluid bolus in a dose of 240 mils of 0.9% sodium chloride. This is you would need give him as a fluid bolus, and if needed you can give him for one more time. That would be the second time, 240 mils again, and for the third time as well, 240 mils again if needed, only if needed. You have to be very careful if there is a real need or not. Then the second example is a 20 kg child with severe diarrhea and vomiting, with dry mucous membranes. He's very lethargic. He's got markedly reduced skin turgor. So what does this mean? The 20-kilogram child and these signs of diarrhea and vomiting with severely reduced skin turgor means he's got severe dehydration, which means 10% dehydration. So this child needs so deficit fluids to be given so that his deficit is corrected, and that the formula is, as I told you, is body weight, that is 20 multiplied by percentage dehydration, and this is severe dehydration, so this is 10% multiplied by 10. So 20 times 10% into 10 would be 2000 mils. So this child has got a deficit of 2000 mils, and that has to be corrected over 24 hours. So we'll divide it by 24 to get the the hourly rate that has to be given to this child for the next 24 hours, so that his deficit is corrected. Apart from that, he would also need maintenance fluids for apart from this deficit. So remember, a child who's got dehydration, you have to correct that fluid that has lost, which is this deficit fluid. But again, I told you it has to be corrected over 24. But at the same time, he would need maintenance fluid. So if for this 20 kg, he would need, for the first 10, he would need 1000 mils, and for the next 10 he would need 500. So that makes it 1500 mils. So 1500 plus 2000, if you divide it, that becomes 3500, which has to be given over 24 hours. So if you do the maths, you will get an hourly rate of uh, fluids which has to be given to this child per hour for the next 24 hours. Then we come to the third example, a child with seizures who could not be controlled with various drugs and is in status epilepticus. Uh, he is now intubated and he's on a mechanical ventilator. He weighs 30 kilograms. So how much fluids he need? Now this child is intubated. He has got a CNS condition. He need maintenance fluids. So we have to calculate maintenance fluids, and then two-thirds of the maintenance has to be given, because this is a condition in which there would be some degree of inappropriate antidiuretic hormone. So if you do the math, so for first 10 kg of this 30, it would be 1000. For the next 10 kg, it would be 500. So that makes it 1500. And for the next 10 kg, it would be 20 mils per kg. So that would make it 200. So 1000 plus 500 plus 200 would be 1700. And of this 1700, if you take the two-third of it, so that would be around probably 1400 something, that has to be given to this child over 24 hours. So that is two-third maintenance. So the key here is that you calculate and you have to give two-thirds of the maintenance fluid. So remember these examples. I wrote it down here to make you understand that the different clinical scenarios in which how fluids have to be given and how they are calculated. So remember, the important thing is you need to understand whether it's a resuscitative condition, whether the child needs maintenance fluid, or whether the child needs deficit fluid. So resuscitative fluids have to be given immediately as a bolus, and after that, if they needed, you can give them maintenance fluids as well. For deficits, you have to calculate deficits and you have to give them over 24 hours. Similarly, maintenance fluids have to be calculated and they have to be given over 24 hours. There are certain conditions in which you will be giving two-thirds of the maintenance, so you should remember those conditions. And especially in kids who have got deficits, you have to calculate deficits as well as maintenance, and you combine them together and you give them over 24 hours. So, my friends, this was a brief lecture on how to calculate fluids and how to initiate fluid therapy in pediatric practice. I hope you have liked this video, and if you have, then thumbs up would be fantastic. And you are new here and you don't know me, so let me introduce. My name is Sayed Kazmi and you're watching my YouTube channel. So if you haven't subscribed, please do subscribe and press the bell notification icon, so whenever I upload a new video, you are always on board with me. So have a very good day. Take care. Stay safe. Bye bye.